Okay, so I was asked to talk a little on the management of first-time patella dislocation. Here's my declaration slide. Let me first say that just before I came here, one of my patients had a pulmonary embolism, and I spoke to the internal medicine specialist and told him I was going to Lyon to talk for 3 days about the patella. And he said to me, "How can you spend 3 days talking about the patella?" And my response was, "How can we cover all of the patella pathology in 3 days for this wonderful bone?" It's different to the other bones in the knee, various shapes. You can see that how it ossifies, the growth arrest lines, as you see, just like Harris growth arrest lines. It's a wonderful bone, and so to Guillaume and Jean-Marie and Sebastian, congratulations for having 3 days on the patella. It's a wonderful thing. So let me talk about first-time patella dislocation. Mostly this occurs in an accident emergency situation. It's probably doesn't intersect with us orthopaedic surgeons initially. So if it remains dislocated, reduce it by extending the knee. Occasionally needs some sedation. But most patients, this happens with the ambulance officer. And then take some radiographs and you'll see the typical appearance of trochlear dysplasia and perhaps slight subluxation. Then the next step is symptomatic control. Occasionally you need to aspirate a hemarthrosis and use ice, analgesia, non-steroidals. And then rehabilitation. Try and avoid braces unless the patient can't mobilise without them. And then the patient's referred to a physiotherapist for rehab, to reawaken the quadriceps, to restore the dynamic constraints. And just like patella pain, you must remember the hip abductors and the core and regularly review. And having happened, the patient usually arrives with the orthopaedic surgeon. And my approach would be to take a history, particularly in relation to factors that are associated with recurrence. The age of the patient, the ease of dislocation, features of generalised ligamentous laxity, high-grade trochlear dysplasia, family history, and the contralateral knee. Look for swelling, and I routinely obtain an MRI, and you'll see the sort of things you can see on this image. The MPFL is damaged, and there's that typical lateral bone bruising. And occasionally you get a surprise, and this patient's lost a large amount of bone and cartilage, and in a setting where the fragments that are broken off are reattachable, then do so. They need to have some bone on them. Simple cartilage fragments alone won't heal, so reattach them when they can. And occasionally you'll see a very large fragment of bone that's come off. And this patient lost almost half of the articular surface of the patella, and it was internally fixed and it healed. So what's the role of early surgery? I think there's a very limited role for arthroscopy and removal of small loose bodies. They're unlikely to cause symptoms, just leave them there. Most patients who have a first-time patella dislocation may not redislocate. Fithian's numbers were 19% at 2 to 5 years. So 10 years ago, if you said to me, who gets stabilisation after one dislocation, I would have said never. And the concept was make the patients earn their surgery. In the beginnings of my training, one of my shoulder surgery colleagues would not do a shoulder stabilisation unless the patient presented with an image like that of the shoulder, and perhaps that was the same attitude for the patella. But we have moved forward, and I'd say that now I do sometimes stabilise the patella after a single dislocation, and I accept it's controversial. So who do I consider might be suitable? Those in whom the patella has come out very easily, often associated with ligamentous laxity. If they've had a contralateral patella dislocation, if they're anatomically predisposed with TT and Cadon Deschamps. I think patients that work at height that have had a single patella dislocation get a little apprehensive if it might come out again, and they're the sort of patients I would consider doing an operation after a single dislocation, and it's something you discuss with the patient, the parents, and balance the risk of the surgery versus the risk of what might happen to them with a second dislocation. So the key points for me in looking after a first-time patella dislocation is always obtain an MRI, fix the fragments that do have the potential to heal. There's no role for arthroscopy with small fragments, lots of rehabilitation early. I accept it's controversial, but some of these patients merit stabilisation after a single dislocation, and hopefully that'll avoid further damage. And finally, let me invite you to Isakos in Boston in 2023. Thank you.